Thank you, and good afternoon. So this is a topic that I'm very passionate about. As I'm slowly working on my DMP, my project's going to be some kind of end-of-life, advancce directive. This just was something I did for my ethics class, which I thought would be of interest. Oh, wrong way. So what I really want to stress here is that it is a nursing responsibility for us to be making sure that patients are aware of their prognosis, aware of their options, and having kind of, starting to initiate those end-of-life discussions. I think for a long time we've really thought this is a physician responsibility, but it isn't, and that's what I'm going to go through and talk about. And I apologize, I have a little bit of a cold, so there's so many reasons why we're kind of in this mess, per se, for patients at the end of life. We have providers who are uncertain when to begin conversations, so they're not sure, is now the time, is it not? Physicians who this has rested on forever, not all physicians, but a lot of physicians, they're about curing and treating, especially some of the surgeons I work with. That's what they do, so this becomes a more uncomfortable, now what do I do, because I'm not actually going for a cure. Sometimes we wait for patients. We think the patient will let us know. They'll talk to us. They'll say, gosh, do I have to continue treatment? What's going on? But patients are unsure too. They are not sure how to start that conversation. We're afraid of destroying hope. I hear that all the time. So patients that are palliative, and I work in oncology, so when they come and we're not able to cure them, I hear our surgeons who send them to us say, well, I didn't want to destroy their hope. I was afraid they'd stop fighting if I told them that this wasn't curable. So basically what we're doing is we're ending up with patients who are getting aggressive therapies right up until the end of their life. They're dying in the hospital, they're dying in the ICU, and really we're affecting the patient's ability to decide how they want to spend their final days and to make important decisions. So really the dying process should be more than just am I DNR, do I want a feeding tube? It certainly shouldn't be taking place in the hospital with pagers going off and IV pumps beeping and physicians and nurses running in and out. That really isn't the important time to have these conversations. They really should be around family conversations. What do we want? What are my goals at the end of life? I tell patients all the time, it's important for you because you want to make those decisions, but it's important for your family because if there comes a time where they find you, maybe you stop breathing in the middle of the night and they're like, oh my gosh, I don't know what to do. They call 911. Next thing you know, there's like this, unending events that happen and the patient's on the ICU, and then all of a sudden the family's deciding, what did they want? I'm not sure. Should we do this? Should we not? Kids are fighting with each other. Then they're living with that guilt. Did I do the right thing? Did I not? They're not sure. So really, it really should begin early, and it should be a continuous process. Patients and their families want this information. They want to make those decisions. If you ask them, they want to decide how do they want to die, what's important to them. Not what we think is important, but what they think is important. I like this picture, his little puppy coming in. So nurses right now are often, and I hear this from nurses when I've talked with them, staff nurses, I'm a nurse, but staff nurses, they'll say, we're left out of the conversation. We're not even involved in it. No one's asking us, we're not part of that conversation. Yet nurses are comfortable, probably more comfortable, caring for dying patients. That's what we do. We're on the floor, we're caring for them, we're caring for their families, and we have this bond with our patients, especially staff nurses that are with them, taking care of them, helping them with their ADLs. We have a bond with them, we have an open communication pattern, and we're comfortable just, chatting with them. We also often notice those subtle transitions from, hey, I think this patient's not doing so well, and I'm not sure that they really want to continue with treatment. Sometimes we notice this before the physician will notice it. Also, our whole philosophy is promoting health throughout the continuum of life. So it's not just about absence of disease. When we talk about holistic nursing, it's not about Do they have a disease? Do they not? It's about how do we promote the best health possible? And I think about the cystic fibrosis. I'm sure you do this all the time. How do we promote that health as best as we can, even in the presence of maybe a terminal disease where they're going to progress and get worse? How can we make them feel as good as possible? So this is our role. This is what we do as nurses, and it's very, very important. If we have over-reliance on the medical model, which we do right now, we're not giving patients the best possible care. I hear this a lot. Patients will say, or providers will say, it's very uncomfortable. I'm not sure how to approach it, but think about the patients. It's very uncomfortable, more uncomfortable for them, and there's a lot of emotional and baggage, and there's so much that we owe it to our patients to really begin these conversations. So multidisciplinary care is important. I'm not saying it's all of our responsibility. I'm saying we're part of this, and we need to take on that responsibility. So what are the ethical reasons why we need to do this? So this is important, and I'm going to talk about some principles and talk about why ethically we need to think about what's involved in end-of-life care. So everyone knows the principle of autonomy. Basically, we're saying patients are responsible, and they should have control. Occasionally, patients say, I don't want to, I want you to talk to my husband instead. That's okay. I mean, that's their choice. But ultimately, they get to make that choice. We need to respect the patient's decisions. We need to respect their ability to make those decisions. Gone are those times when we know best. I don't want to destroy their hope. We need to keep them fighting. It's not about what we want. It's about what they want. So we compromise this autonomy when we don't talk about this and we don't give patients that opportunity. So then we have the principle of justice. So this brings up a whole nother point. What about using resources, especially with skyrocketing care, costs, what about using those resources for care that is futile? So, sometimes we're doing these PET scans and we're trying to get drug companies to give us things that aren't FDA approved because we want to try one more thing. Is that right when it's not unending our resources? Non-maleficence basically says we shouldn't inflict harm on our patients. So make no doubt about it, aggressive, non-beneficial treatments can prolong suffering and prolong the dying process for patients. I don't think I think that's harmful when we do that. We're also robbing the patients of the right to die as they wish. So what if that patient thought, gosh, if I knew I only had, that this wasn't going well and I didn't have a lot of time, but I feel good. What if they had wanted to, go over to Germany to see their relatives that they hadn't seen, or they wanted to make that trip to see their grandkids, or maybe they have an estranged child that they want to kind of try to tie up loose ends. We just took that away from them by not telling them. The principle of beneficence, kind of the same thing, I think, but just worded differently. We need to promote what's best for our patients. We need to be honest and clear. We need to give them that information. Risk-benefit. Hey, we can do this chemotherapy. It might work. It's probably not going to extend your life. Here are the side effects. We might actually harm you. We might make you more sick in these last times. We need to prepare our patients so that they're not rushing into the emergency room and having this, and I tell my patients this all the time, it can be a spiral. It's like rolling down a hill. You get to the emergency room, this happens, that happens. Next thing you know, you're where you didn't want to be, up in the ICU. Give them time to tie up loose ends and spend remaining time as they see fit. So this is specific in the U.S., but it's our professional board, the ANA, American Nurses Association, actually has a code of ethics for nurses, which is interesting because a lot of these things really tie into, and this is our ethical responsibility into these kind of conversations. The first provision charges us to treat patients with compassion, respect, and dignity. We need to treat every patient in a dignified manner, even those dying patients. And patients have the right to make their own decisions in healthcare. 1.2, it kind of goes down and breaks it down. If you've never read it, it's good and important to read. It talks about that nurse-patient relationship and how important that is. And it talks about how we should be making individualized plans of care. So how can you really do that if you're not talking to your patient? So every patient that comes in with a certain diagnosis or that isn't going to survive doesn't get the same plan. I'm always surprised when I have a 95-year-old patient come in that has a terminal diagnosis, and at that point, no one is, as his family, nobody's ever talked about, hey, you know, you're getting to the end of your life. They might live to 110, I don't know, but have you thought about what do you want done? What do you want done if something happens? This could be happening even if he didn't have a diagnosis. This is end of life. You got to have that open, honest conversation. And patients need and want someone they can trust to help navigate them through this. This is not an easy process for them. It's very difficult. And who do they trust? If you talk to patients, they trust their nurse. It's not that they don't trust their doctor, but sometimes they look to us to say, okay, what did he mean by all that? And what does this mean? And what are the next steps? So discussions need to begin earlier. So, you know, how often is it that patients are very sick, maybe can't think right, they're on medications, narcotics, whatever for pain, and they're not able to really think through these things. I think we missed the boat. We should have been having these earlier. And they need to include the family and loved ones because they're part of it. So we need to include them and make this part of it. And the discussions need to be ongoing. So with my patients, when they come in, when they're diagnosed with metastasis and we know we're not going to cure them, that's when the conversation starts. They may be healthy, no symptoms, they may be 30, whatever, it doesn't matter. That's when I talk about it. I talk about, okay, so we can't cure this, and what are your goals? Have you thought about this? Have you talked with your family? I hand them something for an advance directive. And then each time, a lot of times they'll do chemotherapy. We try to find something they tolerate, but each time they progress or something happens or they change, we rediscuss it. So what do you think? What do you want to do now? Here's what we could do. Here's the side effects. Here's the chances that it'll help. So it's an ongoing thing. Also, things change. They may be really all about one thing, and then as it gets closer, they may say, you know what, I don't really care if I stay at my daughter's house to die. I'm really worried about, will you be able to control my pain? Provision 1.3 is really charged with what we need to do because it says that we need to minimize unwarranted, unwanted, and unnecessary medical treatment. So that in a nutshell says we shouldn't be letting this happen. We're charged with advocating and working diligently to help our patients. We have an ethical obligation to do this. And, you know, this is our responsibility in end-of-life care. The third code reminds us that our patients are our first priority, so that's what it's all about. And sometimes you may not be popular with your team because you say, hey, I don't think this is a good idea. You're putting this patient on this clinical trial. They're not doing well, and I've talked with the patient, and they kind of want to like go on vacation and take this time off. So you may not be the popular person, but that doesn't matter. This is our responsibility. So the nursing code really leaves no doubt about it. This is our responsibility, and it's not a suggestion. Basically, for nurses, it's a requirement. So I interviewed and kind of surveyed patients or nurses in the cancer center, both advanced practice and staff nurses, just to find out, you know, what do people think about this? What's their experience? And I found that most nurses had no idea that there was a code of ethics for nurses, which didn't surprise me. Advanced practice nurses were usually more comfortable than staff nurses, but not always. Really, the bigger thing was experience. So the more someone had worked in this area, maybe addressed it, maybe saw the different things, the more comfortable they were. I had one nurse who had training, only one in the whole cancer center, who happened to work in hospice, who had specific training in end-of-life care. So a lot of things that patients kind of told me is that if patients decide they don't want further treatment, I go and get the physician right away. That's okay, 5 minutes. That's okay, but I think that's when we can start those conversations. People also say patients were relieved to actually have someone bring this up. And then I had one person say they had no experience with end-of-life discussions, which I found kind of odd because in oncology that comes up often. This was one scenario which kind of talks about there where the family, they didn't discuss this, patient ended up in the ICU on a vent, family fought, no one could agree what was going to happen, it was just a bad situation. So I'm going to read this word for word because I think it's very profound. Nurses have always been at the bedside of dying patients. Their role in providing the highest quality of remaining life and support at the end of life for both patients and their loved ones is traditional, accepted, and expected. If you talk to patients, they expect that we're their advocate. The nurse's fidelity to the patient requires the provision of comfort and includes expertise in the relief of suffering, whether physical, emotional, spiritual, or existential. Increasingly, this means the nurse's role includes discussions of end-of-life choices before a patient's death is imminent. So this is a policy statement from American Nurses Association. So it kind of tells us, yes, this is where we need to be. This is our job as nurses. So what do? What does this mean? We need to educate our nurses right from the beginning, both in undergrad and in graduate levels. Simulation, that's big now. We do all the simulation. We need to simulate discussions. There was an article I read where they had family members who had lost someone who volunteered. They came in and nurses could talk with them and have these discussions because it's uncomfortable. But in reality, sometimes all I do is listen and then tell them and give them information. It's not like you have to have the right words, you just have to listen. What do you want? What are your goals? And then they'll say things like, what do you think the chances are this is gonna work? How sick will it make me? What are the side effects? We need to talk about ethics more. We need to really educate that this is an ethical dilemma and patients dying the way they're dying is not okay. And we had this discussion at lunch a little bit yesterday that yes, it is our society too. We kind of think we're not gonna ever die and we kind of shelter our children from funerals and their old people are off into nursing homes. And so people kind of think, and I've had that happen. I've had a family member say, my dad, who was 95, was fishing a month ago. My response is, that's great. That's great. He was fishing. If this is the last thing that he does, that's okay. But, death is part of life and it's gonna happen regardless. So education is the key. And then I have references if anybody's interested. Lots of them. Any questions?
So I have one question. I'm going to talk about caregiving, and some of the tools that I wanted to take out to home visits, there was one called 5 Wishes and one called the Conversation Starter. Do you have something like that you give families, or do you just...
No, but that would be great for me to see. I mean, I usually broach it with but it would be good, especially because I think they should be having this at home, and that's usually, we have packets for advanced directive that kind of go through, like how to talk about it, what kind of things you want. So we give them that whole pamphlet, or at least I do, and I say, this is important and you need to go home and talk about it, and then you can call me. We're doing a quality improvement project where we're looking at not just giving them the pamphlet, kind of coupling it with that conversation, but then also calling them later if they're not back in clinic to say, hey, did you have any questions? How's that process going? It'd be great if everyone had an advanced directive. But I'd be interested, well, obviously I'll hear it in a bit, but this is our hospice guy, so this is great.
I worked for hospice for over 15 years. And what I find amazing is that like a significant portion of the patients coming onto the program, the family will say, don't use the word hospice, or don't tell mom she's dying.
Yeah.
And it's like the elephant in the room that nobody talks about. It's just how we confront death.
Right. And there's a lot of misconceptions. So I had a patient the other day say, when I was talking to her about hospice, she's like, isn't that where they just try to get you to die fast? I'm like, no. In fact, there has been a lot of research lately. If you search the literature, patients often live longer in hospice than they do getting aggressive chemotherapy. So I bring that up all the time to my patients because in hospice they're promoting health and life. When you get in chemotherapy, we're knocking their immune system down, we're knocking their ability to fight down. Thanks.